In Chapter 3, we are going to discuss cells, aging, and the immune system. And when we start talking about the cells, one thing that we need to consider is there's two different types of inflammatory responses that the cells will go through that affect us overall systemically. And we have acute and we have chronic. And acute is also known as the immediate inflammatory response. Okay, and so usually when you have an acute inflammatory response, obviously it's going to happen quickly. And I always kind of like to use the analogy of if you cut your finger, the first thing that your body is going to want to do is clot that cut so that you obviously don't bleed to death or bleed out. And that's always a consideration when individuals or patients are on anticoagulants or aspirin therapy, because what the anticoagulants and aspirin therapy does is it prolongs the clotting time. So when you have an individual that's on an aspirin a day, it's so if there does become some sort of a buildup in particular coronary artery, that the clotting time is going to be delayed. It's not going to be immediate as it would be in a normal person with normal clotting factors. So once we have an injury, the first thing that happens is there's a very brief period in which the blood vessels constrict in that area. And obviously, once again, the first thing that's going to happen is there's going to be a brief period during which the blood vessels will constrict at that area. And that's just an automatic response that the body produces so that obviously you don't bleed out. Then the next thing that happens is there's an immediate dilation of blood vessels, resulting in, obviously, if the blood vessels are going to dilate, it's going to increase the blood flow to that area. And also there's going to be an increased amount of fluid leaving the vessels and going into tissue spaces. So picture the vessel with blood and then fluid leaving them and going into the interstitial spaces where they're going to kind of fill in between the vessels, and that's where a lot of our swelling comes from, is from that increase of fluid that fills the interstitial spaces. I don't know why I can't say that today. And this is a typo, I just realized it now. It should say at the same time, not T the same time. But at the same time, the permeability, which is basically the ease of penetration. So when something's permeable, that means that it's easy for something to penetrate through it. The permeability of the blood vessels increases, which allows plasma proteins as well as different fluids into those tissue spaces. The blood remaining in the venules becomes thicker, slows down, allows a process called pavementing, in which the leukocytes, which are white blood cells, to form a layer covering the endothelium of the venule, which means basically this is starting the process of clot formation in that area. And so when we talk about an acute inflammatory response, the inflammation in that area is brought on by the plasma, the protein, and the the interstitial fluids that permeate into the tissue spaces. So that's where our inflammation process comes from. The leukocytes then move along the endothelium in kind of like an amoeba-like fashion. They're kind of almost swimming at a point when they can leave the vessel altogether, which is called diapedesis. So remember, our leukocytes are going to be, which we'll talk about a little bit more in this chapter, our leukocytes are going to be our white blood cells. And if you recall anything from general biology, you know our white blood cells are help us in reducing inflammation, and if you have an infection, they help to fight that infection as well. So once they've left the vessel, they travel toward the site of the injury in a process called chemotaxis, which it's a very kind of long, drawn-out process, but this is kind of broken down almost in a definition form for you. Just make sure that you know what that process is when they leave the vessel and they return to the site of the injury. In the process, chemicals called mediators lure the leukocytes to the inflammatory site where they release proteins to begin the process of phagocytosis. And phagocytosis is basically engulfing and destroying whatever foreign body is in that area. So if we look at, let's say, a bacteria in a particular area, say you have a bacterial infection, a staph infection of your skin or of your finger. So what's going to happen is you're going to see this inflammatory process take place where these chemicals are released, the histamines are released, the leukotrienes are released, and they all rush to this site where the inflammation is taking place. Okay, and these white blood cells, and the reason why if you ever are sick and you have blood drawn and the blood work comes back that you have an increase in white blood cells, the doctor's pretty much going to know right off the bat that there's an infection somewhere, because those white blood cells have increased because they're going to try and engulf and destroy and actually remove the foreign body or the waste that takes place from destroying whatever bacteria that is. And that process, once again, is called phagocytosis. It's kind of like when I remember learning it, they talked about the white blood cells actually eating the debris and the leftover cell material from that infection and removing it altogether. And when we talk about inflammation, once again, if we think about a wound on your finger or a staph infection on your finger, there's something called exudates. And an exudate is basically a fluid that you will see kind of erupt around or in the wound. Okay, if you press on it, you're going to get this little bit of yellow fluid that kind of comes out of it. I'm sure if you've ever got a cut and you see that exudate, a lot of times people think right off the bat that it's infected, or they'll say it's pus, but it isn't. It's actually called exudate, and it's a plasma fluid that contains antibodies to microbial invasion and fibrogen. So what that's saying really is that little tiny bit of yellow, it's a clear yellow basically that comes out, is a plasma fluid, okay, and it contains antibodies to where the microbes are actually entering in that wound area. And if you have something that's called purulent exudate, that's actually pus, and that's usually mixed with blood. And when it says that it's hemorrhagic, that's usually a wound that's a deeper wound or a severe wound that you've had a lot of bleeding with. As a dental hygienist, the exudate that we would see a lot of times with patients that would have periodontal disease is a clear exudate. And when they have periodontal disease, there's a chronic infection that's going on. It's a chronic inflammatory process, not an acute one. And what happens is when a particular area actually gets an acute infection or inflammatory process in, say the patient has an entire mouth of periodontal disease, but say maybe tooth number 2, 3, and 4 have now become infected. If you push on that tissue, that would be obviously an acute inflammatory process because now it's infected, and you push on that tissue, the exudate will erupt from the gingival margin and in between the teeth from the gingiva. And that's how we pretty much know that there's pretty much a bacterial infection going on in the patient's mouth. So our bodies have two types of natural specific immunity. Both of those types use lymphocytes, but different lymphocytes. So the first one that I've broken down is something called humoral, and it's identified as an antibody-mediated immunity. Okay, so this would be something that there's an antibody already in the system that is protecting or providing immunity against getting a particular disease. So with humoral, the B lymphocytes, or also known as B cells, produce antibodies, okay, that protect against extracellular antigens. Now, antigens, remember, is going to be whatever is trying to attack or make passage into the body. So an antigen could be a bacteria, a toxin, a parasite, or a virus. Okay, and those, and once we progress through the semester and we start naming the different parasites, bacteria, and viruses, you'll understand why and how this the B cells produce an antibody that is within your body to kind of almost trick the antigen to think that you already had the disease. The second type of natural immunity is cell-mediated immunity. And cell-mediated immunity is initiated by the T sites or the T lymphocytes. And T cells produce lymphokines, which provide protection against intercellular antigens. Okay, so we're talking about antigens, which is something that, is trying to cause us some sort of infection, but it's in the cell, whereas the humoral was extracellular. Okay, so that was something that was from outside the cell that was looking to get in, and this is intracellular antigens, okay, such as viruses, intracellular bacteria and fungi, tumors. Okay, they regulate humoral and cell-mediated immune responses. Okay, our T lymphocytes are very important because once they go to work, we know that something is going on within our cell, the cell itself. Okay, and remember when we talked about viruses a little bit, the viruses penetrate the cell wall and they continue to gorge themselves into that cell wall until basically they start to break out. They start to break out of the cell wall, and then they're free to go to another cell and attack that cell in the same manner to, permeate and go into the cell and once again gorge. And that's how the viruses will get, people can get so sick from a virus because they're working within the cell itself. So like I said, the T cells are super important because of the fact of how they work from intracellular viruses and bacteria and antigens, basically. So we have 3 types of T cells. We have helper T cells, killer T cells, and suppressor T cells. And usually speaking, if you have any metabolic blood work done, if you go to the doctor and you don't feel good, and they're gonna check. They do something called a complete blood count, or it used to be called the complete blood count was the CBC, and they do a metabolic panel on you as well to see how your liver and kidney and everything is working as well. Usually they check each individual cell. They check your T cells, your B cells, your monocytes, your lymphocytes. They check each cell, and that will give them a really good indication as to whether or not you have an inflammatory process going on in your body. But the helper T cells are needed for antibody production within B cells. Okay, so when we talked about the B cells producing the antibody for extracellular viruses and antigens, bacteria, and so forth, the helper T cells are needed by the B cells for that process. Then you have something called the killer T cells, which are active in destroying foreign cells and the rejection of tissue transplants. So basically, when there's a cell that shouldn't be there, that killer T cell is trying to destroy it, and a lot of times go through the whole process of removing the dead cell and all its waste. And if there's someone who's had a tissue transplant and it doesn't work, whether it's a skin graft or a lot of times dentally we have skin grafts within the patient's mouth, where they take tissue from the roof of the mouth and then they put it on an area that has dental recession and sew it on. Sometimes it works and sometimes it doesn't, because the body is looking at that as something that shouldn't be there, and those killer T cells start to reject where it's moved, where it has been moved to. And then the third is the suppressor T cells, and it suppresses the production of antibodies. So it basically keeps the immune system in control instead of the immune system going crazy or out of control, producing too many T cells, or helper T cells, killer T cells, and the other processes of immunity. The suppressor T cells help to keep that immune system in control. Now, there are conditions where the immune system does go out of control, and we'll talk a little bit about just a few of the conditions, because really this class is infectious disease, not chronic, but the book does talk a little bit about a couple of these kind of autoimmune disorders that people have, so I thought I would just throw them in there and you'll have a little bit of knowledge about them. Okay, so to discuss a little bit about combined immune response. Okay, this is going to talk a little bit about what actually happens when the whole process works together. Okay, so remember, an antigen is something that we don't want entering our body. It is either going to be a bacteria, a parasite, it could be a virus. Anything we do not want entering our body is going to be our antigen. So the antigen enters the body, chemical messages are sent out from the point of entry, and phagocytes, which once again are going to help with the destruction of the dead cells and the debris, phagocytes, B cells, and T cells all arrive at, sounds kind of funny, but all arrive at the seed. So they all arrive, at the point of entry. So they're all getting ready now to decide, what type of an inflammatory process they're going to have. And then they've also brought along these phagocytes, which are going to clean up the mess when they're done. It might be an easy way to kind of think of it. As phagocytes begin to attack, the antigens reach the B and T cells, which begin clonal expansion. So if you think of something that's a clone, it's something that's exactly the same. So what the antigens are trying to do is basically clone themselves. So we can produce a lot of antigens in that area to kill or destroy and clean up whatever this bacteria was that was trying to enter the body. The B cells will form something called immunoglobulin, which is your antibodies. The immunoglobulin participates in the inflammatory response. Antibodies attach to the antigen on the surface of the microbes, causing clumping and immobilization of that particular antigen. Okay, so these antibodies, right now they've all run to the site of injury. They've got phagocytosis. It's going to start eating and destroying the antigens, and when the antigen attaches to that surface, when the antibody attaches to the surface of the antigen, it's going to cause the antigens to start clumping together and be immobilized. Okay, and that's going to help. That's part of the immune response, but that's going to help with the destruction of the antigen. Okay, so our next bullet is it destroys the antigen cell membrane, which we know is the covering around the cell. So in the meantime, more T cells have been produced. The T lymphocytes have combined with the antigen, and then there's a chemical reaction that takes place. Different chemicals are released, and to be successful, the T and the B lymphocytes must withdraw, and then the finished cleaning up is going to be done by the macrophages. Now, I said phagocytosis is cleaning up. Phagocytosis, I think I used it improperly, not necessarily used it improperly. I think the way I used it in the prior slide was a bit confusing. They come to the scene to start chewing up and destroying the cells. They start to eat up this antigen. But what actually cleans up the antigen and gets rid of anything that's left is going to be a macrophage. Just to be clear on that. I apologize if I wasn't clear. So where are we going with talking about antigens and antibodies and T cells and B cells? And why do we think that this topic is relevant when we're talking about infectious diseases? Well, one thing that's super important for us to remember is how someone gets sick, or when someone gets sick, has an awful lot to do with the person's overall health. What type of immunity do they have to that particular antigen? When I actually did clinical dental hygiene, I never ever got sick. I very rarely got the flu shot, but I never got sick. And I always said it was because I had a natural immunity to all these diseases that were out there, because patients would come in to get their teeth cleaned, and those of you that are hygienists out there know they'll come with anything. They will come and say, I was diagnosed with strep throat yesterday, but I've been on antibiotic for 24 hours, so I should be good. They will have dropped down, they'll be on their deathbed with influenza A or B, but they'll be like, I don't want to miss my appointment. So we have patients all the time that would come in and they would be super sick, but they didn't want to miss their cleaning appointment, so which I always thought was hilarious. Or the other thing that they would come in with would be a cold sore, which is herpes simplex virus 1 on their lip, and then, which is super contagious, especially with the exudate that comes out of it, is super contagious. You could spread that anywhere on the patient's mouth, in their eyes, in their nose. I could get it, but they would come in with it and not want to miss their teeth cleaning, which of course, that was where I drew the line, and I wouldn't clean somebody that had an active herpetic lesion. But, so, where I'm bringing all this to you is, let's look at what makes someone immune to something and what doesn't, because as we move forward, we're going to talk more about the different infections and the different diseases that are out there, the infectious diseases, and why some people are susceptible to acquiring them and other people aren't. So as I just said, an active natural immunity is basically when the patient has been exposed to the disease. Okay, so like I said, if I was supposed to get the flu or a cold or, bronchitis or whatever from somebody that was in the office, I always felt that I was immune to it because I'd been exposed to it in the past. Now, I will tell you, we are going to talk about some diseases. Most of the time when you are exposed to a disease, your body will provide you with a natural immunity to it. There are some diseases and some bacterial infections we're going to talk about that you can get over and over again. Those of you that are out there that are, in my age group, which is, like 21 to 22, which I'm kidding, I'm not 21 or 22. In my early 50s, we all got the chicken pox. My son's 32 years old. He got the chicken pox. Once you got the chicken pox, you could never get them again because there was an active natural immunity that your body carried. Now that we have the chickenpox vaccine, they are saying that there is a slight possibility that if you've had the vaccine and you've been exposed to someone that actually has chickenpox, you can actually possibly get a lighter case of chickenpox for the second time. But back in the day when they used to just let you get the disease and let your body build an immunity to it, once you had them, you were not going to get them again. So some things like when we talk about viruses, a lot of viruses, which chickenpox is a virus, but when we talk about, say, herpetic lesions, okay, once you get that virus, you always have that virus. It never goes away. We do not have a vaccination to prevent it, and it just lays dormant in your system. And then there are circumstances that happen a lot of times within a person that they are immunocompromised, so they're maybe run down a little bit. They maybe are going through chemotherapy, maybe have HIV, and it will make that herpetic lesion break out again. So that's something that isn't, you're not immune to it because you had it one time. You keep that for forever. And there are several viruses that are like that. We also have something called active artificial. Okay, and those are going to be our vaccinations, our vaccines. And what that is it's usually a dead or attenuated or an altered form of the disease that's injected into the patient so the patient won't contract the disease. So basically what we're doing is we are immunizing the patient, letting the body, basically we're trying to trick our body's immune system by putting the disease into the patient, and then the body automatically thinks when it's exposed to the antigen, the body's automatically going to think that it already had it, so it's not going to get it again. And that's the case with like measles, mumps. I think rubella is another one. The body, that's where the immunization comes in at. Kind of the same thing with the flu vaccine. We put different types of influenza all mixed into the vaccine and trick your body, because the body, if it comes in contact with that particular flu during that flu season, the body's going to think it already had it, so you're not going to get the flu. All of you that are healthcare workers, you are required by law to have your hepatitis B immunization, and that is another situation where they take a dead form of hepatitis B and they immunize you with 3 different injections to protect you if you would come into contact with hepatitis B during a medical or a dental procedure, which is spread from blood on blood, which all of us that are in the medical dental field know it's very easy to come in contact with hepatitis B. So pretty much now it isn't an issue. When I was first starting out in dentistry, it was a very, very scary disease because it's fatal. So remember, we didn't even wear gloves, back in the day. The gloves and the universal precautions just started. I believe it was early 90s. So it wasn't that long ago that we really started protecting ourselves. So if someone came down with, say you had a little nick on your finger and you worked on somebody that it was had hepatitis B, it would be easy for you to contract the disease from the patient. So now we really don't have to worry about that. Now our biggest fear, at one point it was HIV. That's not our biggest fear. Now our biggest fear is hepatitis C, because if the patient doesn't know they have it and it's unrecognized and untreated, it's highly contagious. And there is no vaccination for it. So that's another disease that we will talk about later on. We also have a passive natural immunity, and that's passed from mother to child through breastfeeding and through the placenta. It usually only lasts a few months, and that's our body's way of protecting that little one before it builds its own immunities up to things. Okay, so breastfeeding is the way to go. I breastfed my son. My daughter-in-law breastfed my granddaughter, and both of us breastfed for a year. My granddaughter is never sick, and my son was never sick. So you really do give them a very good start with immunity by breastfeeding. And then we have something that's called passive artificial. And passive artificial immunity is basically they're going to inoculate you with antibodies. Okay, so it's not something that is a routine vaccination, but if you come in contact or you are at risk for this particular infection, then they would give you antibodies. And the examples that are used are rabies or tetanus. And all of you know that as you're in the healthcare field, we are supposed to have our tetanus shot every so many years, but I believe it's every 8 years now. But I'm one that I will raise my hand and say I am guilty of not updating my tetanus shot, because number one, it hurts like hell to get it, and number two, it hurts like hell because it's intramuscular. For about a week, you can barely move your arm. So generally speaking, if you step on like a rusty nail or you cut yourself with something rusty, you really need to go to the emergency room if your tetanus isn't up to date. The other one, talking about rabies, is we're automatically not going to give people rabies shots. Now our dogs and cats get rabies shots because they are, they're outside and they are in contact with potentially rabid animals, whereas the chances of humans being in contact with rabid animals is slim. But if you do have an altercation with an animal that is potentially rabid, say, I actually have a cousin who is like me that loves cats. I absolutely love my cats, and she has indoor cats, and she kind of lives out in the country, and people just dump cats off, so she feeds them. And she'd been feeding this one cat, and the cat came every single day for breakfast, and so she said, I don't even know what made me think about it, but I bent down to pet the cat, and the cat bit her. Well, to make an incredibly long, drawn-out story short, both her daughters are doctors, and they're like, you have to go to the emergency room. So then she ended up having to go through the series of rabies shots, and her husband had to go through the series because he had been washing the cat dishes out, the outdoor cat dishes. So he was at risk for, if the cat was rabid, for getting rabies also, because he was exposed to the rabies. Or I'm sorry, to the saliva, which is where the rabies is can be carried in. Usually the rabies injection, the first one, is an injection in the site of the bite, which in her case was in her finger, and she said that every one of the rabies injections that she had to have was incredibly painful as well. So usually passive artificial immunity is not something that's routinely done. It's usually done in extenuating circumstances and not very pleasant at all. Okay, so like I said a couple slides ago, where are we going with all this information? I know it's a lot of information. The author of our textbook, even though our textbook is a little older than what I'd like, it's a wonderful textbook. She does say that in the beginning of her book that she expects people that are using the book to have some anatomy, physiology, biology background. So I'm trying to break it down as basic as I can for some of you that don't have as much as others. When we talk about immune disorders, it's basically something goes wrong with our immune system. Why is our immune system attacking us in some way or another? And the first one we can talk about is hypersensitivity, which is basically allergies. And with allergies, the immune system develops antibodies against harmless substances because they are identified by the body as potentially harmful antigens. So you can come across, many different ways of developing allergies. Okay, there's many people that have upper respiratory allergies. Okay, a lot of those are caused by inhalation, breathing in, um, ragweed, dog dander, pollens. Okay, they're in the air. You come in contact with them, and automatically your nose starts running, your eyes start itching. Okay, another way is through ingestion, and that would be having an allergy to something, obviously, that you consume, that you eat. And strawberries, believe it or not, are kind of high on the list of people being allergic to. Shellfish, I myself have a shellfish allergy. That's obviously ingested as well. A lot of kids are allergic to milk and dairy products. People are allergic, now you just see tons of people that have gluten allergies as well. So that is another way to to come down with an allergy. Another way is through injection, and that could be an injection of a medication. Whenever I give an injection, I'm allowed to administer local anesthesia to patients. I sit with the patient and just wait about 5 or 10 minutes just to make sure that that patient does not have some sort of an allergy or a reaction to the medication I've administered. It's the same way in the medical field. If you administer an injection, especially something like an antibiotic, usually someone needs to sit with that patient for a few minutes to make sure they don't have a reaction. Or direct. Direct is another way, a direct contact is another way to come in contact with an allergy, and that would be, something like poison ivy. You touched it, and now you've got, this nasty rash from coming in contact with it. Latex, for those of you that remember the people that were allergic to latex about 10 years ago. Insect venom, like red ants, fire ants, bees, that's going to be a direct contact with that little insect, and people have allergic reactions to them. The symptoms of an allergic reaction can range anywhere from just, you know, a mild rash, an itchy rash, some hives, to something that's life-threatening called anaphylactic shock. Most allergies or hypersensitivity, they are acute. Okay, they come on right now. You get stung by that bee, it is here. It's your reaction is right now. It isn't going to be 3 days down the line that you have the reaction to the bee. Okay. Most of the time, the reason for that is, and once again, I have a misspelling here where I have it as evaded instead of avoided. Most of the time when you come in contact with something that you have a hypersensitivity to, you just tend to avoid it. Individuals that are allergic to or have had an allergic reaction to a bee sting, they might have only had like a lot of swelling in the area. Or maybe they had, I don't know, maybe they got some wheezing. Okay, so now they know they're allergic, and they're probably going to carry an EpiPen from that point on, because if they do get stung again, it could potentially be life-threatening into an anaphylactic reaction. An anaphylactic reaction is something that your body closes down. It has basically gone into overload, trying to develop antibodies to whatever the antigen is. Okay, so most of the time, probably about 98% of the time, people always have a hypersensitivity or an allergic reaction before they have an anaphylactic reaction. Okay, so that's how come they know to avoid coming into contact with the particular antigen that gave them that hypersensitivity before. In my situation, and I will tell you, I have a lot of different goofy things that have happened to me or family members that I share, because I can hopefully make you relate to, I'm a normal person, and some of these crazy things have happened. But this past summer, I was being treated. I'm sorry, I take that back. It wasn't this past summer. It actually started in December. I had subcutaneous steroid injections and ended up with a mycobacterium infection that ended up into going into osteomyelitis in my elbow, which is an infection of the bone, and it's super hard to get rid of. So I was on antibiotic after antibiotic after antibiotic, and I was taking this because they just kept trying different antibiotics to see what they could get to work with this particular strain that I had. So I was on Sulfa. I was on Bactrim, and I had been taking Bactrim for 12 days. Never had one symptom, nothing. No itching, no nothing. And I happened to have a doctor's appointment, and I took my Sulfa with me, and I took it at the doctor's office, and it was in about 10 minutes, my belly started itching. And then it was my shoulders, and then it was my armpits, and down my sides, I'm itching. And I know in the back of my mind, you are having an allergic reaction, but I'm not allergic to anything other than shellfish. Nothing. No medications, nothing. And I kept telling myself, you're having an allergic reaction. But then I had this other side of me that was like in denial that my body could be doing this to me. So I started having a difficult time swallowing. I started wheezing. My nose was running. My eyes were running. And these are all signs of an anaphylactic reaction, because everything was shutting down. Like every single chemical, histamine, leukotriene, everything that was going on in my body right now was shutting everything down. And I thought I could drive myself to the hospital. And my boyfriend said, no, you're crazy, you're not driving, which was a good thing because by the time I did get to the hospital, I didn't even remember the trip to the hospital. And I never waited. They took me in before they took heart attack patients back because I was literally dying. And it was called, it's a different term, it's called anaphylactoid. And that term is used when you have taken or been exposed to the antigen. And in this case, it was the sulfa. You've been exposed to it in the past and had no reaction. And the first reaction that you have is anaphylactic. So I had, quite a scare with it. I ended up spending the night in the hospital, and they, provided me with prednisone and Benadryl, which is an antihistamine as well, to try and calm everything down. And of course, the prednisone reduces the inflammation, so I could start to breathe again and swallow again. So, where am I going with my big, long, drawn-out story to you guys is if you have had or your child has had any sort of just a weird reaction to something, I apologize about Ada and her barking, but when I do this, I can't do it at YSU because it's way too noisy at YSU, so I have to do it at home, and Ada likes to chime in every now and then. So where I was going with all that was if your child or if you have, say, taken an antibiotic and you happen to get a little rash and it just goes away, take that serious. Don't take it that, it's heat rash or, maybe it was laundry detergent or whatever. Take it serious because it can be fatal. And I have known people that have had anaphylactic reactions to bee bites that have died because I was fortunate enough I had a little bit of time to get to the hospital. Some of these people don't even have time to get their EpiPen out. Okay, so just make sure that you take your hypersensitivity and your reactions to different things seriously. Of the skin, but basically what ends up happening is that it can spread to the throat or other areas. Another autoimmune disorder that many people suffer from is asthma. And those of you that are respiratory therapists can probably teach me a whole lot about asthma and what actually happens. But a very basic breakdown of asthma is it's a spasm of the bronchial tubes, and it increases mucosal secretions and swelling of the mucosal membranes. And once you start getting this increase of mucus and swelling of the membranes, we get airway obstruction. So even though the patient can take what it seems to be a breath, it's really a respiration, and they do not actually get an entire breath. So they don't get what they need from the bottom of their lungs. It's just typically from the very top of their lungs, because all the bronchial tubes that lead down into all parts of the lungs are blocked with the swelling and the secretions. So we have two types of asthma. One is intrinsic. That's usually adults, usually not brought on by any allergies or anything. And that's a very dangerous asthma. It is an asthma that there are no stimulators for, so you just start to have an asthma attack. It's not like you walk into my house with my cats and you start, coughing and wheezing, it's, excuse me, it's for whatever reason, you just start having a difficult time breathing, and the swelling and inflammation and mucus starts to build up. The other is extrinsic, and that's usually found in kids or children, and that's usually caused from some sort of an allergen. So if a child is allergic to, say, goldenrod or ragweed, and they start, the histamines are released and they start coughing, and they get a little bit of inflammation in their nasal passage and so on, then it does start to build up a little bit of inflammation. That's not to say all kids have extrinsic. Some kids could have intrinsic, which, like I said, is a much more serious form of asthma than extrinsic. The symptoms, like I said, are coughing, wheezing, thick yellow sputum, which is like a mucus. And when someone has an acute asthma attack, it can lead to respiratory failure as well as death, because they are not getting the oxygenated blood that they need. Treatment for chronic asthma sufferers is adrenocortical hormones. They usually are not used for long-term use. There are a lot of other methods, but this isn't a pharmacology class, so we won't go into those. But we all know that cortisone helps with inflammation, so that would be one of the priorities as far as chronic asthma goes. Someone that you don't just want to wait until you have an asthma attack. You try and maintain it prophylactically. The other thing that individuals use are something called rescue inhalers, and that's a beta-2 adrenergic agonist, which, once again, I'm not going to go into how that works, what the function is, because this isn't a pharmacology class, but this is basically when someone carries a rescue inhaler, they have an asthma attack, they use it, it dilates the bronchioles and allows the patient to be able to start breathing normally. The other autoimmune disorder that we're going to talk about is rheumatoid arthritis, and it's a chronic systemic inflammation disease primarily that attacks the joints, surrounding muscles, tendons, ligaments, and blood vessels. It progresses slowly, so it's not an acute disorder. It's not something you wake up with one morning and have. It's something that's a very slow progression. It can potentially cripple 10% of its victims. So 10% of the victims of rheumatoid arthritis can be completely disabled from this disease. The cause, again, is unknown. It's autoimmune. It's the body, for whatever reason, fighting the body. You see it more in women than you do in men, and symptoms are fatigue, malaise, anorexia, low-grade fever, weight loss. They end up having where their lymph glands are at. The lymph glands do not drain properly, so they end up with inflammation of the areas around the lymph glands, and also they have very vague joint pain. And another autoimmune disorder that you've probably heard of is lupus, and that's a chronic inflammation of the connective tissue. And there's two forms of it. One is cutaneous, and that's very mild and affects the skin. And a lot of people that have cutaneous lupus, they have something that's called the butterfly effect, and it is basically on their face, where from across one cheekbone, across the nose to the other cheekbone is very, very red, almost scarlet red, and it looks like a butterfly. And that's a number one sign of lupus. Now, it can be that butterfly effect can also be systemic, but the cutaneous, which is the mild form, that's usually the only place you're going to see lupus in cutaneous form. In the systemic form, it affects the skin and the organs. So with systemic, you will definitely see on the skin, you'll see the butterfly effect. It can be fatal. It goes into periods of remission or of mild symptoms, and then it can go to very serious or severe symptoms, and then it can go back into remission again. So it's a very vague disease. There's not a whole lot of, I don't want to say prophylactic medication, but there's not a whole lot of answers to how to prevent the disease from progressing. So the biggest thing with lupus is to be diagnosed at an early stage so that it doesn't progress. And once again, it is more prominent in women than in men. So lupus is another autoimmune disease, and it is a chronic inflammatory disorder of the connective tissue, and there's two forms. There's cutaneous and systemic. In cutaneous, you usually, the first thing you'll see is something called the butterfly rash, where it's a rash that continues over one cheekbone, over the nose, and over the other cheekbone. It's very distinctive when you see someone that has it. There is also systemic, which affects the skin and the organs. That is a much more severe. It can be fatal. It can go into remission, or the individual can have just minor symptoms, or it can come out of remission and it can be very severe. It can cause death, and it's more common, once again, like the rheumatoid arthritis, in women than in men. So, finishing up discussing lupus, I apologize on the last slide. It was almost like a double narration, but it would have taken me all the way back to slide 1 to have to re-record. So you will hear the previous slide twice, actually. So just finishing up on lupus, and there's really, like I said, it's autoimmune, so we really don't know what causes it. It's our body fighting against us for some reason. And there's different theories that are out there that it could be mental or physical stress. It could be a strep infection or a viral infection, exposure to sunlight or ultraviolet light, which is obviously using a tanning bed. We always love to throw immunizations in there as causing some sort of disorder with the individual. pregnancy and abnormal estrogen metabolism has also been thrown in as far as possible causes for lupus. The symptoms, basically the same as arthritis. Once again, I talked about the butterfly rash across the cheeks and nose, and there's really not any treatment for mild cases. And if the individual has very severe symptoms, or the etiology is very severe, that corticosteroids have been known to play an effect in reducing those symptoms. So that will complete chapter 3 in our textbook.